Welcome to RUMC Connections. Welcome to RUMC Connections. My name is Meredith Gaskins, and we are joined today by Alex Lutz, the VP of Marketing and Public Relations.
Hello.
And our special guest of the day, Dr. Philip Otterbeck, who is the Chair of Medicine and the Chief of Endocrinology here at RUMC. The thyroid is a butterfly-shaped gland located in the front of the neck. It produces hormones that play a key role in regulating blood pressure, body temperature, heart rate, metabolism, and the reaction of the body to other hormones. In this episode, we'll discuss conditions that cause thyroid problems and the link with obesity. So thank you for joining us again today, Dr. Otterbeck. We're happy to have you back.
Thank you for having me.
According to recent studies, it says some 40% of Americans struggle with obesity. What would you say is the connection between thyroid disorders and excessive weight gain?
Thyroid disorders can affect a person's weight. There are two main thyroid conditions that exist: hypothyroidism and hyperthyroidism. Hypothyroidism is a slow thyroid, and hyperthyroidism is a fast thyroid. Hypothyroid patients, when the patient has abnormal thyroid hormone, that is a low amount of thyroid hormone affects a patient's metabolic rate. So if a patient has a situation where the thyroid is uncontrolled, that is, they're not receiving the appropriate amount of or any thyroid medication, that can affect the patient's weight. Having said that, however, once you normalize a patient's thyroid hormone level in the blood, that would not be expected to affect a person's overall metabolic rate. Metabolism and obesity are very complex clinical conditions that are, to be honest, very poorly understood. We can look at two people, identify that they basically eat the same foods, one gains weight and the other one doesn't. And truly the reality is we don't know why that is. Some people have hypotheses. Is it the gut bacteria? Is it the thyroid? Is it something else that we don't understand? And likely, of the two or three things we do understand about metabolism, there's probably 1,000 other things we don't understand. And because of that, we wind up in this very unsatisfying situation where many of our patients continue to struggle with their weight without success. And part of that, again, is their own endogenous or their own body's ability to regulate metabolism, but also whatever diet and exercise they do on their own. That is, what they're consuming and how much exercising and the output that they're able to implement in their lives.
With these two conditions, outside of weight loss, are there other symptoms that might lead you to think it's something with the thyroid?
Yes. So in fact, these two conditions, you can tell by the names, they're basically opposites. Those that have a slow thyroid or hypothyroidism can complain of a variety of different symptoms, specifically fatigue, weight gain, depressed, constipation, feeling cold, brittle hair and brittle nails. And a lot of my patients will tell me, well, doctor, I have all of those things. And indeed, if you asked probably some of us, are you tired? Well, many of us don't get enough exercise. We don't sleep enough. We don't do all the things that we know we're supposed to do. So a lot of those symptoms can go with, just not sleeping enough or being anemic or other conditions. So it's very important when you have those symptoms to let your doctor know. And especially if you have a family history of thyroid disease, request that the provider check your thyroid blood test to establish whether you have a fast or a slow thyroid or a normal thyroid. If it's normal, then you have to look other places for your symptoms. If it's abnormal, then you may or may not have found your answer. So those are basically the symptoms of hypothyroidism. In hyperthyroidism, it's the opposite. People have a fast metabolism. They lose weight. They feel nervous, they're shaky, palpitations, they feel hot. Some of them will complain about diarrhea. So these are, again, diseases which are opposites, but affecting the same gland. One where the gland is producing too little hormone, the other one where the gland is producing too much hormone.
And it sounds like from what you just said, these are not conditions that a normal blood panel would reveal. You should ask for a specific type of test.
Yeah, so some people kind of ask for like a routine set of blood work. from their doctor, this would not be something that would be considered routine. This is more of a diagnostic test, not a screening test. So, everybody will know the doctor will always recommend, a colonoscopy at age 45, a mammography at a certain age, screening for cholesterol at a certain age and blood sugar at a certain age. In this case, there's no generally accepted screening program for thyroid disease, and thus, if you're having the symptoms that I described, it would be something that the doctor would have to specifically order on a blood test for you as a diagnostic test.
Are there ever scans done instead of just a blood test? Like, can you see something visually in the thyroid from a scan?
Yeah, so scans are a very important part of the assessment of a thyroid. What you'll notice probably is that when you go to the doctor and he or she is examining your thyroid, they will generally feel, it's a butterfly-shaped gland in the neck right here, and they'll be pressing on the neck on both sides of the trachea. The trachea is in the middle. The thyroid is on both lobes or on both sides of that. And essentially, if the doctor feels that there's any enlargement in the area, or if he feels any nodules, which are basically lumps and bumps on the thyroid, if there are any abnormal lymph nodes in the area, the doctor will likely order what's called a neck or thyroid ultrasound, which is to examine what we would call the parenchyma, or the tissue of the thyroid gland, to see if there's any concerning findings, because I'm sure most of the audience knows that some patients can develop thyroid cancer in these areas, and the way to identify that initially is with a thyroid scan or a thyroid ultrasound.
And how do you treat? Is it in medicine, or is it lifestyle change?
For a patient that has hypothyroidism or slow thyroid, basically you just have to replace what the thyroid is no longer able to make. The name for most people in this country with hypothyroidism is called Hashimoto's disease. And Hashimoto's disease is an autoimmune attack of the thyroid gland by antibodies that your body makes abnormally. And when that happens, the thyroid tissue begins to die, and then what we have to do as clinicians is to supplement what the thyroid is no longer making with thyroid hormone. And that, people might know the name Synthroid or levothyroxine or Unithroid. These are the common hormones that we use to supplement what the body can no longer make. Regarding lifestyle changes, I always tell people to have a good, healthy lifestyle, exercise, watch your diet. This is one area where I can't say that this is really going to be necessarily beneficial. I can't say that eating vegetables is going to fix your thyroid, right? I'll tell you that to do that anyway, because to help the rest of your body, but specifically directed at the thyroid, the answer would be no. If we go to the opposite condition, which is the hyperthyroid situation, where there's too much thyroid hormone being made, there's 3 ways to treat hyperthyroidism. One is with a medicine called either PTU or methimazole. Those are medicines that slow down the thyroid gland to render the patient what we would call euthyroid, or biochemically euthyroid. In English, it means normal thyroid function test. So that medicine is geared towards slowing down the thyroid gland. The second approach is to do what's called radioactive iodine. And what you do is you give the patient a radioactive pill. Over the course of 6 or 8 weeks, that pill will destroy the function of the thyroid gland, and then rendering the patient hypothyroid, and then they'll need the Synthroid or the levothyroxine for the rest of their lives. And lastly is surgery. People that want the condition fixed immediately, they can undergo a surgery to remove the thyroid gland, and once that's done, they'll become permanently hypothyroid, and they'll have to take Synthroid forever. Those are the 3 options for the treatment of hyperthyroidism or fast thyroid. They're all considered 3 acceptable approaches.
Yeah.
There's different styles, different people and physicians train differently.
Yeah.
In Europe, actually, they do more surgical intervention for hyperthyroidism than we do here. Here, we place more of an emphasis on avoiding surgery, and also the scar that people will have sometimes in the bottom of their neck. All of them are considered reasonable and acceptable approaches.
Similar to in the previous episode when we talked about diabetes, you said that they're being diagnosed at a younger age. Are you seeing more thyroid issues younger than in previous years, or is it still somewhat of a later onset type condition?
We do see the hypothyroidism and hyperthyroidism in youth, but still it's more of a condition that we see more in adulthood, and thyroid cancer especially is while it can happen in children, it's more unusual. In adults, we see a lot more thyroid cancer than we do in children.
And Staten Island has one of the highest rates of thyroid cancer in the state. What are some of the risk factors, symptoms of thyroid cancer?
It's actually a reasonably disturbing statistic. In 2021, there was a paper published that looked specifically at the risk for thyroid cancer in Staten Island as compared to, say, the rest of the city. And they identified in the study that there was a 67% increase in thyroid cancer in Staten Island as compared to New York City as a whole. In the paper, there were some proposed reasons, environmental reasons, that could account for some of this. One was the fact that a lot of the material from the 9/11 attack was brought over to the Fresh Kills landfill during the event. That was one hypothesis. The second hypothesis was also the Fresh Kill landfills itself. I mean, I know I've grown up on Staten Island my whole life, and I certainly can remember that wonderful aroma when we came out of our homes.
From space.
Yes, exactly. So that was a second idea. And then the third idea is that perhaps the medical community, of course, in Staten Island is very close, and we take very good care of our patients, which I'm very proud to say. And perhaps patients are going to the doctor here and more than maybe perhaps other places, and we're identifying more disease. Really, nobody has the firm answer to this question, but that number of 67% is really striking.
That's very alarming.
And thankfully, we have the providers both at RUMC and on Staten Island generally to take care of these conditions. But nevertheless, it's unfortunate that the number is so disproportionately elevated as compared to the rest of the city.
And what are the symptoms of thyroid cancer?
So many times, nothing. It's something that would be identified on physical exam by the doctor. When a patient has thyroid cancer where it has become symptomatic, what they could be experiencing is difficulty swallowing, voice changes, or simply when they look in the mirror, they'll see themselves and they'll see a little bump on their neck in this area, and so that is what the initial thing is, which calls attention to both the patient and to the clinician as well. So it's important. If you feel something in your neck, tell your doctor, and then that doctor will assess whether a additional workup, particularly with ultrasound, would be indicated.
And is it a very treatable form of cancer?
It tends to be a very treatable form of cancer, especially when the cancer is identified in early stages. And most of the cancer that we find, thankfully, is caught in early stages. It's treatable certainly in later stages, but those are the areas in which you can see some cases, mortality cases. But most of the patients that we're going to find, we're going to identify them, we're going to treat them, and they should have no ill effects on a long-range basis. And in the vast majority of cases, it will not affect people's longevity at all, especially when found early.
So if somebody was diagnosed with thyroid cancer, would it just be the removal of the thyroid, or would they try to do chemo or radiation first, or what's the process?
So first step is identifying that there is a problem in the thyroid. So you'll get the ultrasound, and then you will say to the patient, okay, you have a lesion there, it needs a biopsy. Now, the good news about thyroid nodules or thyroid lesions is that most of them are benign. 95% of all nodules are benign. 5% of the time they can be cancer. The other thing is 2/3 of people, if we just do sonograms on everybody, 2/3 of people will have small thyroid nodules. So that's why we don't recommend doing an exam for everybody, because you have to think about it in some sense as a variant of normal if 2/3 of people have something. So really what we want to do is identify the people that have clinically relevant nodules that necessitate a biopsy. So when you do a biopsy, it's a very simple procedure. We bring the patient to the office. And in our practice, we can do it right there, and I see the patient, and then we say, okay, we need to do a biopsy, and that same day we bring them in the other room, we lay them down on the table, and basically in 10 minutes the procedure is done. We numb the area topically, we put the needle in 3, 4, 5 times depending upon what specimen we get and what return we get, and then we send the material off to the pathologist, and we come up with a diagnosis. Assuming the unusual circumstance where it actually is cancer, then we have to tell the patient, okay, this is what we have, and we need to send you to the surgeon. And depending upon the size of the cancer, we either remove half the thyroid gland or the whole thyroid gland. So it's a surgical disease, and thus the intervention is surgery. And when we remove the whole gland, of course, people need thyroid hormone for the rest of their lives. When we remove half of the gland, some people do, some people don't. About half do, half don't.
So you can live without your thyroid if you have to remove it. You'd be on medication, but you
be on
can
right.
remove it.
But and especially if you remove the whole gland, you would not be able to live without the thyroid medicine. So this does cause some people some anxiety about that. But thyroid medicine is cheap; it's always available. So we shouldn't worry about that. But it's something that we talk to the patients about. But look, we're going to remove your thyroid. You need medicine forever. Otherwise, you can't live very long without medication if your thyroid is out. And then in some cases, we do radioactive iodine, which is we give them a radioactive pill. And that radioactive pill, the thought is it can decrease the chance for recurrence, and in some cases decrease mortality long range. It's very simple. There's no real chemotherapy. There's no nausea, vomiting, nothing like that. So that is a small subset of people we're giving the radioactive iodine to. And then if somebody has advanced disease, there are other medicines. They call them TKIs, tyrosine kinase inhibitors. And those medicines are for people that have stage 4 advanced thyroid cancer. That's a very, very, very small sliver of people that winds up in that condition needing those medicines. But they're much better tolerated than, say, what we would imagine of typical chemotherapy, where people are having vomiting and losing their hair and all the things that we have in our minds, what we would think of as chemotherapy.
So let's talk a little bit more about Hashimoto, because you said that falls under the hypothyroidism.
Yes.
And does that progress in any type of way, or just the medication that you take for the hypothyroidism regulate that and it doesn't have any effect on the rest of your life?
Yeah, well, it shouldn't really have an effect on the rest of your life, but it's critical to identify the disease because first of all, you need to have the right amount of hormones in order for all the body's physiologic processes. Literally from head to toe, there are receptors for thyroid hormone. So if you have too much or too little of that hormone, you're not going to feel well from head to toe. Does the dose of hormone change? The answer is yes. Hashimoto's can be a progressive disease in that sense. People start off maybe on a low dose of medicine, maybe 25 micrograms of the levothyroxine, which is the lowest dose, and then over time that might go to 50, 100, 200, 250. So it is a dynamic disease in that over time the condition, the Hashimoto's disease, will destroy more and more and more of the thyroid to the point where it becomes non-functional. But it's important to identify that, because whatever the thyroid no longer makes, we have to supplement from the outside such that the sum of the circulating hormone levels will be appropriate to the body's physiologic needs. So if you miss when the body is slowing, then the patient isn't going to feel well despite the fact that you're giving them medication. So that's why we continue to check the hormone levels intermittently. In the beginning, we check every 3 months and then maybe every 6 months. And then when people are really stable, we can go down to once a year. But there are all sorts of things to keep in mind symptomatically, but also other things that affect people's lives especially when a woman becomes pregnant. That will change the dose of thyroid hormone that you need. But also something as simple as starting birth control pills. If you start an estrogen-containing birth control pill, it will increase your requirement for thyroid hormone, and so thus the dose will need to be increased. So if any woman is out there considering birth control pills, it's important to remind the doctor doing the prescribing if you have a thyroid condition, because it can affect the level.
That makes sense. So you would tweak the medication for when someone is pregnant, and I'm sure you would end up having to do the same a little bit later in life for some of your women patients, especially when they're going through menopause, because that's a slew of hormonal changes as well, right?
That's exactly right. And in fact, often what happens is, and probably as the audience knows, as the amount of estrogen that the ovaries are producing decreases, sometimes there can be a decrease in the need for thyroid hormone. So at menopause, we certainly do see that sometimes.
Yeah. Now, do you see more thyroid issues in women or men?
Thyroid condition, all autoimmune conditions, and in this case we're talking about Hashimoto's, which is an autoimmune condition, and hyperthyroidism, which is also can be an autoimmune condition, something called Graves' disease. Yeah. In Hashimoto's, you're destroying the gland. In Graves' disease, you're stimulating the gland because the antibodies are binding to the receptors on the gland and stimulating it. So both of those being autoimmune conditions tend to be more prominent in females as opposed to males, and consequently, we do see a predominance of those diseases in women. Nevertheless, we can see it in men, and especially in those with a potent family history of those conditions.
Is there a specific age that you start to see thyroid issues presenting themselves, where somebody who might be going for their physicals, where they say, hey, I've reached this age, I should be requesting this thyroid test?
So the short answer to that is no. We don't recommend just broadly screening for thyroid disease. We do recommend, though, when you have a symptom of either hypo or hyperthyroidism, that's when you should check. And really, with respect to hypothyroidism, the symptom can be as benign sounding as dry skin. Dry skin can be an early sign of thyroid disease. So if you're having dry skin, you're having brittle hair, you're having fatigue, any of these things, you should at least be screened for a thyroid condition, because again, it can manifest that way, and if you don't look for these things, you don't find these things. And it's fairly simple: seeing the doctor and getting the blood test. That's about it. No special procedures, no scans, no. It's pretty benign.
So as an endocrinologist, we're talking about the thyroid and the glands in the body as we move away from the COVID-19 pandemic. Are you seeing in studies or even in your own patients, did the COVID-19 virus have an impact on the endocrinologic system in people?
Yes, we do see that and in a variety of different ways. One of the treatments that people tended to use for COVID was steroids. People will recall in the beginning we were told maybe we shouldn't use steroids, and then subsequently they told us we should use steroids for certain patients. So steroids have the capacity to raise our blood sugar very significantly. And in some patients where those steroids were utilized, coupled with the stress of the illness, tended to raise individuals' blood sugar and certainly tipped maybe some of the pre-diabetes patients over into diabetes. It's also interesting that viruses tend to be the precipitant of many autoimmune conditions. So type 1 diabetes, lupus, rheumatoid arthritis, thyroid disease, all of these are considered autoimmune conditions. And COVID was no exception to the general view that once you get a virus, there are many times that it increases your risk for developing some autoimmune condition, and we've certainly seen that in the endocrine world with thyroid disease.
So it would still behoove people to consider the vaccines as they come out, in your professional opinion, or if you don't want opinion, it's
No. I give my own information. I got the vaccine myself. I don't really have many medical problems. Nevertheless, it's I want to protect myself as much as I can from COVID, both from the standpoint of my own health, but also I see a lot of patients every day, and I certainly don't want to be carrying something and give it to them. Sure. So, but I would say, so long as a person is eligible for a vaccine, there's very little downside to these vaccines, and only a potential upside. It's certainly true that it is a different disease state and a different situation that we exist in as compared to 2020 when it was an unbearable amount of disease and very sadly death. But luckily now we don't have that, at least to the degree that we did. But if I think about the kind of the risk and benefit, I still would err on the side of taking the vaccine for our patients, especially when they have advanced age or lots of comorbidities.
And what else would you see are some of the more popular endocrine-related cases in your office? Is lupus fairly high on the island, or other conditions?
With respect to lupus specifically, that would usually be handled by my rheumatology colleagues. Okay. But in my office, I would say about half the patients are diabetes-related patients, whether it's type 1 or type 2 diabetes. Yeah. about 40% are thyroid-related conditions, and then 10% kind of other stuff. And what would that other stuff kind of entail? Individuals that have polycystic ovaries is one. People with disorders of the pituitary gland. The pituitary gland is a gland that sits in the brain. You can develop little tumors of that and some hormonal disturbances. So we see individuals with those diagnoses. Also problems with the adrenal gland. An adrenal gland are glands that sit atop the kidneys. Those can develop a little bit of nodules and hormonal abnormalities. And so we see individuals with those cases, and sometimes they need surgery, sometimes they don't. So endocrine really kind of affects, it encompasses a wide variety of conditions. The other very common thing that we see in our practice is osteoporosis, which is bone disease. It may not strike the audience as typically an endocrine disease, but our osteoporosis falls under our category because bone health and bone mineralization can be a consequence of hormonal disturbances. So people that have abnormal periods, people that have low testosterone, people that have hyperthyroidism, these are all conditions that predispose individuals to have the deteriorating bone function. So it's expected that the endocrinologists treat, diagnose, and manage individuals that have osteoporosis.
And for all of these different conditions we've discussed, is there any things on the horizon that have you excited, have you hopeful for the treatments?
There's all great things that are coming out in a variety of these different areas, but one of my passions really is really seeing an end to type 1 diabetes. And type 1 diabetes, I know we talked about it in the other program, but I'll briefly summarize it here, is an autoimmune process by which children wind up needing insulin for the rest of their lives. And essentially, what we need is a pump, an insulin pump that individuals can attach to themselves and interface simultaneously with a continuous glucose monitor, and basically be able to increase and decrease the amount of insulin infused depending upon a patient's blood sugar. Once there's that true closed-loop system, these individuals will be able to live their lives like anybody else with the benefit of this technology. And you might say to yourself, well, we do so many complex things in the world. We send people to outer space. And how can it be so hard to have a device that measures sugar and administers insulin and just to make people euglycemic or have normal blood sugar? And it turns out there's a variety of reasons why it's complex, not the least of which is the lag time between these devices measuring the sugar underneath the skin, the interstitial fluid, and the blood. There's a lag time between those two things. The companies are working that out. They're really working hard at it, but I hope that in the next 3-5 years, we might be able to see an end to this condition that really affects people negatively as they grow older, and it really makes it a really tough condition for people, especially as they are kids and as they go through adolescence. And of course, you can imagine, as anybody that has their own children, can you imagine worrying about your child's blood sugar overnight? They go away on vacation, you worry about them constantly, and that would be really a dream for these families to really put an end to this. And then, of course, with type 2 diabetes, there's always new stuff coming out, and marrying that to the condition of obesity, we're seeing more and more medications coming out to treat obesity. Basically have to wait for the insurance to catch up with that, and in terms of coverage, and then hopefully people can derive that benefit from the weight reduction over the course of their lives. So.
Well, thank you for joining us and for your time today, and for all that you do to keep us safe and healthy. That about does it for this episode of RUMC Connections. I'm Meredith Gaskins.